Hi, I'm Dr. Frederick Marais. I'm a member of the ICAN group, and I'm also working in the Western Cape government in South Africa, and part-time also a lecturer at Stellenbosch University. There's been a lot of debate recently in the social media and also other forums about some of the missing links in the current Ebola control responses, and sometimes quite tense debates. And to me, one of the real missing links, a true missing link perhaps, is community engagement in that control. By that I mean we really need to work in partnership with communities who are affected by, first of all, validating their community knowledge as the insider experience. They know the conditions, the lived realities, but also to bring them on board that we can work with them. So if we respect the knowledge, we validate that, we integrate that into our responses, hopefully we build more of a trusting partnership, because a lot of responses at the moment, it seems to be sort of fueled by fear, panic, sometimes myths as well. So what I feel we really need to start thinking about is, even beyond Ebola at the moment, is how do we engage broadly with the communities. For example, if there's an affected community, we should identify who are the key community leaders. Importantly, not only the men but also females, who play a very important and respected and trusted role within that community. Once we work with them, we can then discuss what is our protocol in terms of how we prevent infection transmission or disease containment. Why do we need to take certain steps? And then we can compare that with what I will refer to as the community protocol. That means the cultural values, the customs and the practices. We can identify, are there any of our steps we're taking from a disease control perspective that might be culturally insensitive. Then we can debate and say, can we make slight modifications that we don't compromise on safety, not spreading infection, but equally we recognize there's a community and a cultural context within which we operate, and we need to find a midway. And perhaps then through debate, through dialogue, by building trust, that reciprocal learning, because I will enter the community with cultural humility, meaning I've got the openness to learn. I don't enter by saying, this is what you ought to know. I go in with an open mind to say, what can you teach me? And then what can I reciprocate to teach you? So we work as a partnership. Then we can perhaps come up with sort of a joint Ebola or a disease community control approach, that we understand where the community comes from and they know why we need to take any steps. So therefore we won't just arrive suddenly unannounced in the community. We will do it with respect, accompanied by a community member, and also then the community leader or the chief could call a meeting with a broader community to explain, this is the situation we have in terms of Ebola, these are the steps that the infection control team need to take for these reasons. This is how they can adapt it slightly to still be in line with our community protocol, or some aspects we can't change because of the nature of the disease. And we really need to work on that in a sustained way. It's not a project, because from a community perspective, there's a lot of concern about the conventional way we tend to work with research as well. We arrive suddenly in a community, we do work and we leave. And we don't leave capacity behind. And this time we need to do differently. Work with them, think beyond Ebola, really building that structures, build the knowledge in the community, that ultimately the community can do it for the community, for their own benefit. So when we leave, the control teams, the rapid response teams, that capacity remains. So we can avert future outbreaks, or the community can early on recognize there are certain signs, symptoms, people are affected, and to take action immediately. So it is about long-term prevention, it's about treatment and about self-care and understanding of why certain steps are necessary, and work collaboratively in a supportive and a trusting manner to really, as a team, because I feel communities are co-partners in health, they're not just a passive recipient. So by changing our view and working with the community, hopefully together we can have a better impact in improving the health for self, others and a broader community as well.
Thank you very much, Frederick. How long have you been in the field to come up to all these conclusions? Of course, I understand that you have your background, but how long did you spend in the field to really fine-tune the recommendations you are giving us today?
Yeah. Right, I did my doctoral studies. I've started off first of all in South Africa. I worked here for many years, then moved to the UK. I worked in TB control, HIV control, sexual health. Then I realized that what was missing to me was that community component. I got quite disappointed, disillusioned with the conventional approaches, so I needed to educate myself. What are other ways of doing it? So I got in touch with networks in the United States and Canada, where this sort of approach has been used in multiple settings, and there's evidence that the communities together with the Department of Health or academics can make a difference, but it comes from within the community. So I've done that since about 2000 when I got my doctoral studies. I've worked in London for a while, then I came back to the UK, to South Africa. I worked in infection control unit, and we really try to look at critically how do we engage the communities. And now I'm working in a Department of Health, government level, and again we're really saying, look, we need to change what we're doing, modify, and really work with the community. So in terms of what we're trying to do with Ebola now, I'm pulling in on the expertise of people in different countries, but critically also communities currently directly affected by Ebola. We're coming up with the very key steps how to engage with the community, but before we can hopefully release that through ICAN, we're taking that to the real communities and ask them, look at this. Would this transfer into your community setting? Is that aligned with your cultural protocol? And already we got very, very good ideas coming from the community. They pose questions how we can maybe slightly modify our infection prevention control practices. But of course, ultimately it must be a decision that's based on science as well and evidence before we can just change it. But already the community is excited about this. They recognize it's a need, and we want to get them to really help us to shape the steps and ultimately a new model that we want to call the CARE model, standing for community, assets, responsiveness and evaluation, so that we can hopefully try to move away from a fear-based response to Ebola or other viral hemorrhagic fevers and have one that's based in care, that we work together.
Thank you very much.